And thanks for everybody for joining this Thursday. Happy Friday Eve. Hopefully, a lot of people are out of the month-end close for October as well. So if you're working, treat me as a podcast, if you like, in the background. Nothing wrong with getting two things or three things done at once. I have this headset on today, so I'm kind of like the co-pilot or air traffic controller. However, uh, we need as many of those as we can get, as I understand it, with our friendly government shutdown, which is also going to be a topic today about how it relates to some of the things that are in this stopgap bill. What does it mean for what CMS proposed with some of the rates? What does it mean for dish funding and people with insurance? So we're going to cover a lot today, there's a lot of slides. In fact, really what we want to address with this group today is absolutely what's in the final rule. The final rule this year, in any case, has three interesting parts that impact the way that our hospitals are reimbursed. One is how the rates are made. So we're going to kind of get into the details of that, what the market basket means, and all the associated budget neutrality adjustments that impact that market basket and what those budget neutrality adjustments represent. Because as these budget neutrality adjustments get larger and larger, what they do is they eat away at the market basket adjustment because the money's being kind of pushed and pulled in different directions across the country. So we'll talk about that. Talk about what's going on with wage index. I guess the headline is now 72% of all hospitals across the country receive their state's rural floor wage index. And so there's been a lot of discussion around that. There's been discussion about urban hospitals that have converted to rural status and so forth. And so we'll kind of look across the country and see that activity. One of the addendums we have is actually looking at the payment changes. If we go back to 2023 through 2026, what does that look like if you're an urban hospital, a rural hospital, or even as we're calling it a urban hospital, those hospitals that are rural or urban that have converted to rural status. And we did that. And that's, if you look at the agenda here, we won't go into that detail today. Again, this is a resource document for you all. You could take a look at that in Addendum B. Pretty interesting stuff. And the third, the big thing with the IPPS rule this year is what's going on with DISH and uncompensated care. Certainly, the UC pool is up. The question is, what's driving it up? It's actually interesting. It's related to some of those ACA tax credit premiums, which are one of the deals that's in this stopgap piece of legislation. So it's there's some interplay between what's going on in the federal government right now and actually how CMS projects and looks at the rates that hospitals are paid. So we'll get into all that. There are other things in the IPPS rule we won't get into a lot of detail on. There's some minor tweaks to GME. We'll talk about allied health, and allied health is actually it's a sensitive subject these days in terms of the amount of disallowances that are going on. Just cover team, just as a reminder, because it starts January 1, 2026. So if you're a mandatory participant in that program, just a reminder what that's all about. And as Ryan said, we'll get into the OPPS. The OPPS rule this year actually has more what I'll call payment changes in the downward trajectory as compared to the IPPS. And that's where CMS is moving to things like site neutrality and getting rid of the inpatient only list and this 340B remedy they want to accelerate. So there's a lot of things in there that are that don't help what I'll call a traditional year-over-year update in outpatient reimbursement. So what CMS says, if you go into the IPPS final rule, is that there's a $5 billion influx of new revenue to providers this year. Again, that's a national number. Majority of it comes from a $2 billion increase to the uncompensated care pool. The rest really has to do with, general market basket updates and how the wage indices work across the country. One of the things that's interesting in here, and this is actually a part of this continuing. So the name, I believe, and anyone on this call can correct me, I believe the name of the stopgap bill that's a part of the government shutdown is this continuing appropriations and extension Act and Other Matters Act of 2026. So the big piece of that act is, and what we read about are those ACA tax premiums and, pretty much what the Democrats want to see are those tax premiums staying, I think, indefinitely, enabling more people access to ACA under the marketplace. But other things are also in that legislation, two of which are the low volume extension of the low volume adjustment as it currently is, and it has been for the past 10 years or so, as well as the continuation of the Medicare dependent hospital status. So for anyone that has those hospitals or in states with those hospitals, just know that the extension of those programs is in this bill. I don't think that that's a holdup of the bill, obviously, but it's just a piece of that. It's a piece. So we'll see as things unwind and there's more bartering, what sticks and what doesn't. But currently, it's not the reason the government is shut down, but it is a part of that bill. For those providers that are in a CBSA with the wage index over 1, what CMS does, I think it's about every 3 years, is they pull cost report data and they look at the percent of costs related to labor and non-labor expenses. And what CMS found in 2026 was that the percentage of labor costs are actually about 66% as compared to 67.6. And what that means is if you have a wage index above 1, now it's being multiplied, whatever that wage index is, times 66%, which is that labor portion of the base rate instead of 67.6. So you lose a little bit and from that adjustment. Across the country, if you're curious, this is what the rate increases look like. This is based on our analysis, including the rate changes. What we do when we do this, we keep discharges constant. We do update for CMI. We try to keep dish and IME and some of those other variables constant. So we're trying to measure what's the change in the version grouper update with all the different DRG weights. What's the change from the increase to the base rate, which we'll get into momentarily here. Obviously, this accounts for any changes to the wage index for any particular provider, and then the uncompensated care payments. So across the board, we have it at about a 4% increase nationally. You could see, how the states line up here. This number, though, does include, because over 10 years, Medicare dependent and low volume have been extended. So we said, okay, we're just going to, in order to keep, year to year, apples to apples, those we're assuming in this case that those programs are extended. If they weren't, this national increase of 4% you see here would go down to more of a 3.3%. So it does eat away, obviously, at the rate increases. And it would obviously depend on your state. And if you're one of those providers, I know there's many providers in particular that go after or file for the low volume adjustment under the relaxed criteria. And actually what we heard and what we understand about what's in that final rule when it comes to that low volume status is if it is extended, we look for CMS to kind of come out with another application process, because right now there's really nothing that can be filed. Many providers don't qualify under the old criteria. So one of the things we always talk about too is when the rates come out, the headline that's on the CMS press release is what the market basket update is. So the market basket, in this case for 2026, was advertised as 2.6%. And if you look, though, and if you actually look across the rate tables, and as being very specific, when the rule comes out, it comes out with a number of data files and tables. The number one table, though, table 1A through, I think they call it 1E, are what the base rates are. What are those labor and non-labor rates? And that's in an addendum too. If you're curious the exact number of what those rates are, we have them here in an addendum. So if you were to compare, instead of saying, okay, CMS updates my rates by 2.6%, well, that's not true. When you compare the rates from last year to this year, that update's only 1.94%. And the reason why we're showing so much information on this slide And if I had my laser pointer, I would point it out to a better degree. Is because every year that when the rates come out, the past not every year, but the past few years, they've come out and we go, okay, it's going to be if we were back in 24, 2.3% increase, but bam, it goes back down to 1.9. Same thing last year, 25 came out, it's going to be a 2.6% increase. No, it went down to 195. This year came out, we thought we were hopeful again, knowing based on history it would change, but at 3.19, and we're down to one back, but pretty much where we have been in 25 and 24. So when we talk about growth, right, and we talk about the need for accelerated, even if you listen to MedPAC, they'll say every year CMS needs to tack on 1% to their market basket adjustment. Well, that's good, but it's not an issue. It's just how money goes between states, we have a lot of different things that shifts money around in the IPPS system. And this is what it looks like, at least from the perspective of your operating rate. So, and this we're geeking out a little bit here, but we want to provide as much education as we can. And so the way that this works, and this is in the rule, it's like one of those, it's like buried way in the back. I don't even know if it has a table name, but there's the science in terms of how all these budget neutrality factors are applied. And what they do is they start with the prior year operating rate, but they strip out the prior year's budget neutrality factors. They leave in the inflation or the market basket because you have to compound that. But they strip out the prior year budget neutrality factor adjustments, and then they add in this year's budget neutrality factor adjustments. So you could see that there's a flurry of them. We don't have to get into the weeds of what they all mean, but as you kind of scroll down, you'll certainly see they get larger and larger, and you see this reclassification budget neutrality factor adjustment. What I'll say is, and just to be candid, Toyon is exploring CMS's accuracy on how this budget neutrality adjustment is put together. These budget neutrality factors are a series of what if questions. What if payments were one way, but now payments are this way? So in many cases, that starting point, we question, well, CMS, you're assuming a really low starting point for these what if scenarios. And we speculate that that's the case with this reclass budget neutrality factor. In any case, it reduces rates by 4.3%. And that's a large reduction. And that has to do with things that go on with wage index, whether it be geo rate classes or the impact of certain rural floor adjustments. And that's why we said kind of coming into this presentation, there are a few things to pay attention to. One is how the rates are made, right? Because this is why it's not a steady 2.6% adjustment. There are a lot of things that come out of the rates so that money can be dispersed in other markets depending on what's going on in those other markets. But like I also was saying, is we don't always trust the way that the rates are made. In fact, we've caught CMS in a few of these examples here these are the active appeals that providers across the country are pursuing. If you're not a part of these appeals, I suggest you learn a little bit about them just to make sure your hospitals are covered. But there are three pretty big ones. The biggest actually popped last year, but there's some interplay between this first budget neutrality appeal and this second transfer DRG appeal. All of these things go way back to when the rates were established. I think the first year of PPS was federal fiscal year 1984. And so, some smart people have gone back and questioned and have seen things with exactly how the rates were constructed. And I'm going to skip to this standardized rate first because that came first. I think this popped in about 2018. It was discovered that in developing basically the cost base, which the base rate represents the cost per patient, that CMS included transfer DRGs when it was improper, because when you include those, technically they're not total inpatient stays, and there's some language on how they should be treated, but ultimately those transfer DRGs should have been excluded. Thus, the cost per discharge would be higher. Payments would be higher to the degree of about 0.89% every year. And there's a lot of that appeal has been going on. I want to say it was just not discovered, but became prolific in about 2018. So again, one example of, okay, CMS, we're catching you a little bit with how you do these budget neutrality factors. You're not always right. And we're hopeful that there's some success. Last year, another appeal popped, and the reason I brought up the standardized rate appeal first is I don't know as for certain, but we were already deconstructing the rates as they were developed from those 1981 cost reports used for federal fiscal year 2000 or 1984 IPPS. During that process, it seems to me, it was discovered that, or even if it wasn't during that process, in a parallel world, it was discovered that CMS also missed another budget neutrality adjustment when they were constructing the rates all the way back in 1984. There was supposed to be a 1 year budget neutrality period between reasonable cost-based reimbursement from when we shifted over to IPPS and that budget neutrality adjustment to keep the federal outlay at zero was 5.92%. That was Congress intended that to go away, and it never did. And so since 1984, our rates have been adjusted downward by 5.92%. And so last year, about this time, maybe a little bit earlier, this appeal popped, and we're hopeful CMS will make it right. Going back to that theory of these rates aren't always as accurate as we want them to be. Lastly, just so you know, the third, and you used to see, remember when the rates were set, for those of you that follow the market basket, there was these labor and productivity adjustments, documentation and coding adjustments. A lot of that was related to when CMS moved from AP DRGs to MS DRGs in 2008. There's a lot of misfiling of how things were grouped and ultimately paid to hospitals. So there was an $11 billion take back, but CMS was supposed to restore that $11 billion back into the rates. And ultimately they fell short in 2024 by 0.9412%. And so that's the third appeal. Again, just going to show that the rates are already low due to these issues. And so the market basket isn't really getting us to where we need to be as an industry. The other thing that's happening right now, and it's this, I think people are calling it OB3. I heard someone call it Bubba recently. I thought it was a good name for it. So it increased our deficit. And so over a 10-year period, about $340 billion. Every year, we're at risk of having this pay-go implemented. Every year, though, there is some piece of legislation that basically stops the government from pulling that lever. This year, it's a little bit more dicey because of the BBA. My understanding, and again, there's two things that I understand that I need that we're continuing to track. One is it's a 4% sequestration. There's been some debate on, well, we already have 2%. Does that mean it's another 4%, or is it only another 2% that can go up? I've heard both, to be honest with you, and I think it gets pretty technical. What I would prepare for, there's a possibility of another 4%. And in any case, any further sequestration is horrible for our industry. So I always applaud and the people that do the government relations work that have to go in and do their best to make this not happen. I mean, that's a big lift. So I applaud the work that they do, and I hope that there's success this year as well. The second piece is, my understanding is we're not going to really know about this until January hits. Has to do with Congress makes the decision 14 days after the end of their session, which basically puts us in mid-January. So as we get into the end of 25, early 26, maybe we'll get some more updates on this with the government shutdown now. I don't know. I don't know what kind of communication we'd have, but this is a huge risk on providers and something for us to pay attention to as well. So, and this is the section of our presentation this is like the doom and gloom section, but there is hope, and we'll communicate all of that. And always there's strategy and things that I know that you all work on to best position your operations for success. But some of the other funding, and these are real deals. So the big thing that came out with OBBA was these caps on provider fee programs, whether it be on the revenue side or how much can be paid to hospitals through percent of Medicare versus average commercial rate. We know that there's a difference between how expansion and non-expansion states are treated. Either way, though, there are limitations for growth in the future. So that's hard, right? It's causing us to kind of rethink perhaps how some of these plans are designed and how to make up for some of that shortfall. We've been kicking the can on Medicaid dish payments since the implementation of the ACA. And so in this Continuing Appropriations Act, there is another proposed delay to kick the can until federal year 26 into 27. So we'll see again, but those are some other looming cuts. Again, the 24 billion, I think, is over a 3-year period. It's 8 billion a year. And so there's an algorithm on how those all fall down on each state. In any case, the message is it's reductions to the funding. We have less patients with insurance, and this is the holdup right now with what's going on within the federal government with, like I said earlier, the tax premiums and the extension to include those tax premiums to provide more people access to the ACA marketplace. But currently, if we have less patients with insurance and a reduction in Medicaid dish, one of the things that we're looking out for is, well, hey, if you're close to qualifying for dish, absolutely think about what some of these changes to Medicaid enrollment mean to your hospital. If you are close to qualifying for 340B at 11.75%, we'll think about, hey, maybe, again, this kind of goes to another theme of our presentation, but in order to hold on to 340B, sometimes the only option you have as a non-for-profit hospital is to apply for 340B at the 8% threshold, which means if you qualify for rural referral center status, you'd want to get it. But these are some of the implications of lower Medicaid utilization. There's also implication on the UC dish pool, which we'll get to pretty soon here. Then, and this kind of speaks to later on in the presentation when we get to outpatient, but amongst all of this, amongst all these cuts to patients with insurance, to dish, to the market basket, we also have CMS saying, well, we want to shift more payments to site neutrality, meaning we want to pay hospitals as doctors' offices, not as complex hospitals anymore. And they're starting with what they proposed in the OPPS rule with drug administration services. They want to shift more services to outpatient, meaning you have a larger push into ambulatory surgery centers doing certain things that only hospitals would do previously. And then we have these fun alternative payment models to just add layers of complexity in terms of how we're reimbursed and put additional reporting burdens. And I'm not saying these are bad programs. It's more on the plate of all of us to figure out how to be optimally reimbursed. It's a hard job, absolutely. Considering all these things. Okay, this is the last doom slide, I think. So CMS is also monitoring. They say they want to improve uncompensated care and over a 10-year period reduce the federal spend by $230 billion. I read that like 5 times. I didn't understand how that would be achieved, but it's the biggest number in there. They also talk more about site neutrality. And what this is too, if I back up, this was released March, maybe before that, when they were kind of looking at, well, where can the Fed save money? And the reason why we continue to have this in our presentation is because these are common themes. We've seen a lot of this before, especially when it comes to the elimination of Medicare bad debt. CMS has talked about not paying for that. They list what's going on with hospitals converting from urban to rural status, saying that there's savings, but that can be debated. And we'll just leave it at that for now. Reform of GME, I think we would all agree. If anything, we need more in the GME space. We're still limited at 1996 caps in large, so that's kind of silly. But the elimination inpatient-only list, absolutely something they're proposing. Like I said, they've already started this movement here, and the latest would be in the 2026 outpatient rule. Talked about this earlier. If you're curious more about Medicare dependent, low volume status, what the basically current criteria and less strict criteria are. That's what this slide shows. It also gives you where to find, if you're curious about reading more, the extension of these programs. These are all hyperlinks. So this presentation will obviously be public to everyone. And so even through a PDF form, you could click on it and be brought right to the source documentation. Another piece before we get into more of the meat and potatoes of the presentation, just real quick. There were 39 DRGs that went up by 10% or more as compared to last year, and 28 that were held harmless at 10% because you can't go down more than 10%. This is something that impacts budget neutrality, although not by a great deal. This is a public service announcement. It's not something that's in the rule, but please remember, especially as you're doing your 2025 cost reports this year, to watch out for the change in the outlier criteria. Previously, hospitals were flagged for getting an outlier reconciliation based on 10 percentage points. Now it's 20%. So like a math example would be if your cost charge ratio is 30%, if it went up to 40% previously, you'd be flagged because that's 10 percentage points. But now it just has to go up to 36% because it's a 20% change instead of 20% or 10% points. So just watch out for all that stuff because those are certainly labor-intensive projects if you're flagged for that reconciliation. Also, just what CMS does is when they publish the proposed and final rules now, I don't know if they'll continue to do it, but they do provide a new public use file that says if we had changed our criteria using, before 2025, who would be subject to an outlier reconciliation, just to give people a flavor of what some of those settlements would look like.
Fred, I have a quick question.
Absolutely.
Are you aware of any talk out there about adding an outpatient component to IME?
I did hear something. I'm trying to remember where I heard it from. Yes,
Same here.
yes, there is. And if you don't mind, let me scratch my brain for a little. It might come to me as we're doing this presentation. But that's a great point, and I did hear that chatter, and we'll certainly circle back on that. But thanks for bringing that up. Okay. So wage index. I'm going to let my buddy Ryan. Do you want to just give everyone a little overview here, homie, on just so how we all remember how this whole process works?
Everybody's favorite topic, wage index. Sure.
Yeah.
Be happy to. And I'll just go back just briefly, to give you a break here, Fred. I was thinking as you were talking about the update to the rates and stuff, you said national, and maybe this is a question here. Nationally, it's a 4%, right? And I was doing the math in my head thinking, well, the market basket after budget neutrality is it's like 2. How do we get to 4, right? And that's uncompensated care and some other things that are maybe not budget neutral. Reminder, wage index is budget neutral, in all aspects of it, right? We've got a couple different budget neutralities that we'll talk about a little further here as we go in. But this slide here, this slide here is just kind of a preview. I think we've probably had this in here the last couple years now. They really haven't changed the variables of how wage index is calculated, in terms of we've got like this third what is that, a magnifying glass or something there, this 5%, right? That's been around for a few years. You cannot read, your wage index cannot be decreased more than 5% from the previous federal year. That's been in play. They made that permanent a few years back. The rural floor we'll talk about here, that's a big part of the wage index. I think Fred had mentioned 72% of hospitals now receive their state's rural floor. And so we'll get into all that. But this, again, it's just kind of a reminder of some of the different variables that impact your wage index.
Yeah, thanks, Ryan. And just as the color I'll provide to this too, for those of you, there are some, and we do this work, and there are probably others on this call that do this work as well. Ryan and I have been curious what the government shutdown means to some of the geographic applications that have gone out. In short, CMS has 60 days to approve hospitals for rural and rural referral center status. So what a lot of hospitals do is they file. You can't file for that status until you're in the last quarter of your year. So a lot of hospitals tee that up so that they get rural or rural referral center status before the MDCRB meets to decide on whether or not the hospital can be reclassified. And this is just a quick heads up to the group here. With the government shutdown, we're not sure what the timelines mean anymore. So if you're doing that work, if you're doing geo reclasses and filing rural status, just something to pay attention to. We certainly are. And we're going to continue to do our diligence, but it does throw a wrench into some of the timelines, I believe.
Thanks,
Go
Fred.
ahead, Brian. Yep.
And that goes what you're talking about, Fred, that speaks to the strategy around wage index, right? In terms of reclassifying and we'll talk a little bit briefly about rural floor optimization and that sort of thing. And a lot of that stuff's up in the air right now, like Fred said, with the government shutdown. But it still doesn't, again, that's the strategy. But what this slide speaks to is what I'll describe as kind of I like to use the term blocking and tackling of wage index, right? Which is your average hourly wage data. And what we've seen over the last few years is interesting, right? And so the bottom line is if you're not keeping up, the way wage index works, right, is if you're not keeping up with the national average hourly wage increase, your wage index as a factor is going to be decreased. So if we look at this slide, you can kind of see the trend line. Historically, if you go all the way back to say federal year 22, 23, well, actually 22, once you hit 23, then it starts to change. 2, 3% was sort of standard, right? I mean, it sort of coincide with COLA increases and whatnot. Then all of a sudden in 23, we see a 5%, then 5.5%, and then 9.2% in federal year 25. That's unheard of, right? 9.2%, in average hourly wage. And that's primarily because of COVID. We added the base cost reporting here years, right? Federal fiscal year 2021, right? So that's if you're 12/31, that's your 12/31/21 report, 6/30/22, right? So those are pretty well impacted by COVID. And we're all in the industry, right? We all know what happened with nursing shortages and, contract labor and registry folks that had to come in and were paying absorbent amounts, right? And now we're starting to see that kind of level off, right? As people really focus on these cost cutting efforts. And so 26, it went up 5. And now in 27, we're seeing, what Fred's trying to show here is if you take 27, if you just take the data, the unaudited data, we're seeing a 4.2%. However, there's a number of hospitals, 11 in particular, that we identified. This was in our analysis that extremely aberrant, like $17,000 an hour or something absurd, right? It just somebody fat fingered something and it just needs to be addressed. So if you normalize that, we're at 1.2%, which is even below what we historically. So that's interesting too, right? We look at the data all the time. We see a lot of decreases, across the country, which is not normal. But again, that points to the cost-cutting efforts that have been going into controlling your contract labor and all these things. So it's just kind of an interesting slide just to kind of put in perspective how things are shifting because of COVID and over the last few years. And we'll see how this all normalizes.
Absolutely. And what I would just add too is if you look at your own uh, S3 Part 2 or however you measure your hospital's average hourly rate, maybe this aligns with what you're seeing, because like I said, what we're seeing when we look across many of our country's beautiful CBSAs, that we are seeing incremental increases or decreases. And maybe that makes sense with the leveling off. We're not paying traveling nurses as much anymore. Does that make sense? Right. That's the question. But we'll certainly see the next public use file where this stuff is audited comes out in February. And I guess the other update, Ryan, what you're seeing is not a lot of wage index audits this year. Is that correct?
Yeah, I was going to comment on that because you just mentioned the unaudited. I'm sure a lot of you, I mean, if you guys are involved, if you all are involved in your wage index reviews and the audits of that, you've probably seen that there is a lack thereof, right? So we sort of heard rumors that they were quote unquote de-scoping these audits in 2027. And it's actually, I mean, as far as I've seen, it's come to fruition, right? I've not dealt with any auditors from this perspective. In fact, out here, Noridian sent out an email saying all their I'm in California, by the way, all their reviews are done. And it's October. I was like, how's that possible? And so it's interesting. I'm curious, and this goes to kind of the aberrant data perspective. I'm curious if CMS is going to step in after the fact and really pay attention to anything that is aberrant, because if they're not really engaged in reviews, it does make you question the integrity of the whole system a little bit. As much as we all obviously didn't, we always would roll our eyes when the auditors would come in. We know they've got a job to do. So, anyways, we'll see how that plays out too. My understanding is that is a temporary thing, and I won't get into the weeds of it, but there was mention of it in the final rule that they have to approve some Information Request Act or something through the OMB, and that just didn't happen. So they are contractually not allowed to do these reviews at this time. So I presume that'll be rubber stamped and moved on. But again, in this administration, who knows? So we'll see. But
Ryan, we have two comments on that. So
yeah, please.
there's no audits in Buffalo, and there is audits happening in Pennsylvania.
Really?
Yeah, so
So
inconsistency
Buffalo would be
there.
NGS and Pennsylvania with Novitas. Maybe Novitas didn't get the memo.
Yeah.
I'm sorry to hear that, Pennsylvania folks. Yeah,
No audits in Arizona as well.
yeah,
So
that's
thank you everybody for sharing. Separately, Ryan, have you ever dissected or looked into how the outmigration factor is calculated?
ooh, that's
Ooh.
real weedy stuff.
Yeah.
Yeah, I frankly I have not. It's they update those every few years, I believe, every 3 years, right? Thanks, Fred. Um, and that goes to employee commuting patterns and different things. That's real weedy stuff that frankly I just, like I said, I
We
never dove into.
we've talked about it. Yeah,
Yeah.
you have to get into BLS data and a lot of actuarial science, I think is the right word. But it's a great question because I think that's the theme of everything we deal with is do we trust what Medicare's telling us?
Hmm.
No. No, I mean if it was just me doing it, I wouldn't trust myself. It's a lot of work. When you look at all the things that have to be done, of course there's going to be mistakes, and so it's our job as an industry to find them, right? So that we're appropriately reimbursed.
Yep.
Especially in light of all these cuts. So
Another question,
oh,
with all this wage index audit review carry forward to OPPS and
ooh.
any impact on the 2026 OPPS, which is a new OPPS year.
Correct. So OCMIX, for the folks on the phone, this is every 3 years, right? And using calendar year data. The next anticipated one would be calendar year 2025, impacting your federal year 2028 rate. So in theory, those would be due July next year. So, start planning accordingly. However, we have heard that that needs to be rubber stamped to go forward as well. So I don't have a crystal ball here. I have to assume that it'll happen, but just we'll be keeping an eye out on that as well. But I think by all accounts, plan accordingly that those will be due in July of next year as well. So, all right, let's keep moving, I suppose.
No,
There's other
yeah,
questions, Daniel. Certainly, let's chime in. But
yeah.
we want to move forward to, we've got some trends here, and this goes back to the strategy that we talked about. I mean, you can see, the pickup, this first columns here on the left, hospitals receiving the rural floor wage index, as Fred had mentioned, 72% of hospitals in the country. And why is that happening? Well, that goes to, I don't think we had mentioned it, the change in the way the rural floor is being calculated. CMS made that change in federal year 2024 due to all this litigation that was happening, right? And so that kind of that changed the game, I'll say it, in terms of states optimizing or at least utilizing the rural floor as means to increasing their wage index. And how do you do that? Well, that goes to these Section 412, 103 hospitals, which you've seen the pickup there, 812. So what's that, like a third of, not quite a third, maybe a quarter of hospitals across the country are urban hospitals that have designated themselves as rural. And there's various reasons to do that, right? I think a lot of the folks on the phone know there's pickups in your IME as a result of that, but it also has a lot of implications on your wage index. And so we don't need to go through all these, but ultimately you can see that trend line of hospitals utilizing that status for various reasons. And part of that too is, if you're getting the rural floor and you have an opportunity to get an increase in your IME, then there's no downside, right? A lot of the downside associated with being rural has gone away. And so that's why we're seeing, these numbers pick up. But if you're looking into that, or if that's something that your hospital has not done, that is looking into because there's potentially something there, you need to be very mindful of how it could potentially impact your wage index, and that again goes back to the way they've changed. CMS has changed the calculation for how the rural floor is computed in 2024. So, and we won't get into all these, but Addendum D, we can see the rural floor wage index analysis by state. And there's like, I don't know, 13 or 14, 15 states where 100% of hospitals in that state, in those states, respective states, get their rural floor, right? And then a number is where it's 97% or something, you know?
And I would say something we also learned too is um, when it comes to the impact, there's this, we tend to think of things as well, is this a red versus blue state issue, or is this a rural versus urban issue? This is really a state by state issue. One of the things we always like to bring up, and we talk about the impact that this has across the country was, well, there was a time before the ACA that every state had its own budget neutrality factor, and that was how CMS regulated the activity. After the ACA, that budget neutrality factor was put national, and that's kind of why it's a state by state issue, and that's why we broke it out if you wanted to see. But what we also learned is every rural hospital does benefit by this provision, because what's happening is the rural floors are now set by hospitals that are also redesignated as rural, that have higher average hourly rates. So it does have a positive impact to rural hospitals. So the conversation's complex if you're involved in it. And that's why we were hoping that some of these addendums might be helpful in describing what's transpiring.
Mhm.
Ryan, I'll keep going if you don't mind,
Yeah, please,
homie.
go for it.
Yeah, this is what we talked about earlier. So this has to do with, well, what's going on with budget neutrality? So there are, well, I think it was about 15 years ago, maybe plus or minus. There was a huge wage index settlement on, again, something CMS did incorrectly. They miscalculated the rural floor budget neutrality factor. Back then, the rural floor budget neutrality factor was a part of the operating rate. As a result of the appeal, CMS wanted to be more transparent with what that factor is and how it impacts your wage index. So if you look and you're calculating your hospital's wage index, you effectively in 2026 have to reduce it by 2.6%. That's i.e. it's the same as the 0.9740 budget neutrality factor adjustment. Okay, so that's the whole everything we're seeing here, right? That the light blue line is CMS basically wanting to be more transparent. But are they really more transparent? Because at the same time, still buried in the rates is this other geographic budget neutrality adjustment that has also been on a downward trajectory since the change in CMS's rural floor policy. Again, we're looking into this in kind of further detail, something we're paying attention to, because in our opinion, at least the darker blue, it's blue, Ryan, or is that purple? Blue?
No, I'll say blue. Yeah, we'll say
Ah, all
dark
right.
blue.
All right.
Royal blue.
Is likely overstated in our opinion. So a lot of work has to be done to kind of prove that out, but it's a lot of funding to be coming out of those base rates to pay for everything.
And last thing I'll say there, thanks, Fred, before we move
Yep.
to Dish is, and you can see the trend lines, right? I'd mentioned before the change in the rulemaking in terms of how the rural floor is being calculated in 24, and now we're really seeing that pickup in both budget neutralities, right? So I mean, bottom line is the rural floor activity, if you want to put it that way, is impacting your payments by almost 6-7%, which is drastic, right? And that's where, like Fred said, we're questioning the accuracy of that, and we'll certainly keep folks apprised as to what we identify as we move forward. But the bottom line is, if your state's, and it's a food fight right now with wage index, right? And if your state's not involved in some sort of optimization, you're paying for it via these budget neutrality factors, unfortunately, right? And that's the game that's being played right now until Congress comes in and addresses wage index that we know it's a messed up system. Let's face it, right? This is the game that's going to continue to be played because in CMS's mind, this is budget neutral, right? I mean, what do they care? And
Well,
the last thing I'll mention to Fred's point is this isn't a political thing in terms of, red and blue states, they both benefit to some degree from this, right? And some states really don't have the means to optimize it, and others do. And it's just, unfortunately, it's, part of the system, the way it's set up right now. So,
thanks, Ryan.
yep.
All right. Well, this, I don't know, is this good or bad? I mean, it's good news because it's more money. Bad news because we're getting more uninsured patients. So it's not really more money. It's just more in the IPPS system. So, but the pool is up by 35% this year. So, if you think about it this way, and this is on the cost dollar, 2025, hospitals were paid 17% of their uncompensated care cost. And in this year, which we're 9 days in, hospitals are being paid 23% of their uncompensated care costs. So what that also means is you could have even had, and I don't have the exact number, I'll get close. Your uncompensated care costs could have went down by over 20% as compared to last year, and you still would have broke even. So that's the impact of CMS adjusting the pool. And this is what the pool looks like. Every year, we have about $34 billion in uncompensated care currently. And you could kind of see that this year is the biggest term in terms of reimbursement of the $7.8 billion. Again, as we talked about earlier, a lot of this has to do with, well, and I'll show you in a second, there's two pieces, two components of this. One is factor one, how the pool is established. And then factor two is the estimation of the change in the uninsured rates. So both factor one and factor two were positive in 26 in terms of compared to the prior year. Factor two is the interesting one where CMS again uses this national expenditure data to project uninsured rates, and they do include the expiration of the tax credits. So if those tax credits don't expire, I don't think CMS can do anything about it. I hope not. But it is a part of the reason why the pool is what it is. The other thing that we've heard is kind of on providers' minds too, just as it relates to, well, what is the world that we live in and operate today? Well, unfortunately, we're going to have more and more people eligible for charity care. And some hospitals give really, really generous charity care at like 500% of the federal poverty level. Well, and it's unfortunate. And I'm not saying this is something certainly that has to be done, but providers might look at reducing their charity care thresholds so that they can potentially, be paid in other ways. Hopefully, enrolling a patient in insurance would be one. Because as we get more and more uncompensated care, or more and more people falling off of Medicaid, and we have more and more uncompensated care, the feds pay 23 cents on the cost dollar. And then some of this might be used in state payments, but it certainly is a problem, and it's a big deficit that hospitals continue to face. So just interesting discussions around that. So again, like I said, how does CMS set up this UC dish pool? Well, the first thing they do is they look at this factor one. What factor one is they take old data, and I think it was 22, maybe it was 23, and they mark it up to present value. In other words, if something happened in 23, like what were the dish payments in 23, because that's CMS's starting point, what would those payments be in 2026? So they have like 4 or 5 years of these markups that include changes to the market basket, changes to discharges, case mix index, and the infamous other bucket. But we're kind of out of the woods with what I'll call COVID data that put these numbers into decline. So as we get out of the years impacted by COVID, like 2021, and we start to get more into 2022, then those negative impacts go away. So in the next slide, we'll see that actually the factor one adjustment is a big reason that the UC dish pool's up this year. But the second certainly is factor two, and that's just measuring what is the change in the uninsured in 2026 as compared to 2013 before the ACA, which that base year is the base year of uninsured before ACA was 14%. So we don't have to get way into the weeds here. A couple things I just wanted to show, and a reason why it shows proposed to final is because last year we were kind of excited. We're like, okay, we're going to get $6.5 billion of UC dish, and they came out. I was like, oh, wah, it's 5.7% or $7 billion, and was actually a decrease from the prior year and was not sustainable for this fund. And a lot of that had to do with, well, CMS changed their projection on that factor two from 62% to 54%. If you look this year, CMS didn't change it, right? Again, so this factor two is a big reason that the pool is what it is. But if we rewind and go all the way to the beginning, this is where there's some interesting discussion. So just thinking, again, we'll see how this all plays out in the future. There are $13 billion of base year payments. So what CMS does is they take Medicare cost reports and they say, what would empirical dish payments be if there was no UC dish pool? Meaning 100%. Right now, empirical dish is reduced to 25, but what if it wasn't? What's interesting is we actually see from last year to this year it going down. Well, why would that happen? Well, we could be seeing a transition of patients with fee for service going to Medicare Advantage plans. That will decrease the UC dish pool. So that might already be happening here. But what we are keeping our eye on is, well, we have less patients that are going to qualify for Medicaid. That means Medicaid dish percentages are going to go down. Some hospitals will not qualify for Medicaid dish. What's this $13 billion going to turn into as a result of that? Because that's the starting point. So just something to think about when we think about the impact of OBBA. And then here's that factor one. So like I said, this year that markup to the present value was $3.5 billion, which was a lot more. Last year was 600 million. So a lot more was tacked on before we got into this factor two portion, which again reduces the pool based on the uninsured rate. And you could see what the final payments are here. So interesting stuff as as the legislation and the way that the world operates impacts even our side of the business when it comes to how these funding pools are set up.
Fred, do you want to mention anything about that MedPAC presentation and the trends?
Yeah, I will, and I'll just say MedPAC, and we do have a slide later, but I'll say that they support another way of reimbursing hospitals for dish, more looking at, our current methodology really focuses on, at least for qualification purposes, the Medicaid low-income population, where MedPAC is more interested in measuring the low-income Medicare population and basically changing the way that the whole system would work by that measurement. And UC Dish would be a component of that change, and they're actually proposing to dump in another $4 billion into the pool. The reason we haven't seen that happen yet, though, is until there's industry consensus on a lot of these things, they'll never happen. And so providers want to understand, well, what's my individual impact? And no one's been able to see it. So there's that level of trust, I think, is the reason why we haven't seen that come to fruition. Thank you, Daniel. The other thing that's hot off the press is, so I had this slide, and I always, every year, like, okay, I'm about to do the presentation. I'm like, oh, legislation came out. Something happened. So real quick, update these slides. I feel like I have to put stamps on them or something, So that's what this is. It's a stamp. And what it represents is there was good news that came out of the Montefiore case at the end of September. Pretty much, and again, we're learning more, but the DC District Court ruled that CMS was not my favorite two words, but they're two good ones: arbitrary and capricious, and was not should not have engaged in retroactive rulemaking. They don't disagree with the treatment of the Part C days being in the Medicare fraction versus the Medicaid fraction, but they did take issue with the fact that CMS went outside of their bounds to apply that retroactive rulemaking. So that's good news. What we're waiting for next, and this is all also impacted by the government shutdown, is the court ordered a motion for summary judgment, which means CMS, what's the remedy? And I think that's where things got held up in Alina at some point. And that's kind of where some of this circular reference, some of this retroactive rulemaking began to begin with. But this is good news. So hopefully, the folks you're working with on some of these very ancient dish cases are in touch with you, providing as much guidance as possible, because there's certainly been a lot of activity. One of the things that you've probably seen come across your desk a lot this year are, cost reports from like 2006 that are being NPR'd. And this is why, because the CMS is really trying to close out these cost reports. But every time there's a new court ruling, I wonder if the juice was worth the squeeze. But this is a good update. So Daniel, this is what you're talking about. I won't get into this, but this is that MedPAC slide. CMS brings up MedPAC's proposed changes to DISH, and they've done so, I think, since MedPAC released this report. So we'll see. Again, my take on it is you need industry consensus to make such a bold move to change how Dish is reimbursed and understand the perhaps unintended consequences, et cetera. But there is a proposal out there. GME, I'm not going to get too much in the weeds. Just know if you're doing a cost report and one of the 3 years used for the penultimate prior or current year cost reports is a short period. CMS clarified the treatment of how to calculate those FTEs. So you could read about that if that's impacting you. The other thing is CMS did not finalize so how you basically offset revenue from expenses for nursing and allied health programs. When I saw this, I was like, okay, my issue with allied health is, and this is another kind of public service announcement, is if it hasn't happened to you yet, just keep your eyes peeled. If you're a part of a health system, what's currently been happening is the MACs are under a CMS directive to really take a hard look to see if you are the operator of the program. And a lot of hospitals, it started out here on the West Coast with Noridian, but I know WPS has been engaged somewhere in the Midwest and some of this stuff as well. It's little things, and the most common is if you're paying salaries out of your home office, then CMS doesn't think that you're the operator of the program. They disallow the allied health expense. There's been a lot of cases going through the PRB on this. PRB, in my opinion, is not impartial, unfortunately. So I would think that these will have to end up in court. But I'm hopeful in the success of that appeal, only because it's a weird thing for CMS to go after. Daniel, is there a question there, homie? I see a.
It was just a comment. NGS is also disallowing
Okay. Thank you.
Minnesota if you're part of the system and pay from the home office.
Thank you very much. So for those that are about to start team, I'm not going to go through too much of this. I guess what I'd say is on this, what does this current administration really want to do? When they came out, and I'm not saying that team's going to go away, but what is this going to be a theme that continues to proliferate into other alternative payment models? Because that was the intention of the previous administration. Hey, all these alternative payment models are good for business. They save the government money. There's more quality for the patient. But what they also are is a reporting burden. And they're also duplicative and a lot of other ACO type of things that you might be involved with, which if you recall, when the proposed rule came out, CMS said, tell us what's bothering you. We want to deregulate things because we think that people are reporting too much information. Tell us how to fix all this. Well, here's one example that probably drives people nuts. The way this stuff works, though, is, we'll see, right? So team is mandatory for a certain number of CBSAs across the country. It starts in January. It's 30 days post-care, and it's basically, did you come above or below CMS's benchmark for how much they wanted to spend on whoever that attributed patient is. So I think we'll all be learning a lot. It's super complicated. If you look at the final rule, it would be like this thick if it wasn't for team, but it's like this thick with team. So it's like it's many, many pages of reading information. In terms of what they propose or they finalized is they have a new measure that begins in program year 3. They use this area or community deprivation index over the area deprivation index for their safety net. And they have some other things. They keep MDHs on this track too for safety net hospitals. They actually have a low volume threshold, which I saw some people comment that was interesting because CMS kind of canceled its low volume or the low volume adjustment expired, but there's still a low volume threshold in team. And there's some neutral scores that they're applying here. But this is certainly like niche stuff. If you do this work, good for you. It's definitely could probably make a whole career out of it for sure.
And Fred, we have a question if there's any implications of team on the Medicare cost report.
Not that I'm aware of yet. What I'd say is interesting is one of the things that CMS proposed on the Medicare cost report in the outpatient side are the average reimbursement rates for Medicare Advantage plans. So, if Medicare Advantage started to reimburse based on these types of programs, you'd have to figure out what that reimbursement is. But No, at least as far as I know, there are no cost reporting implications on team. It's all measurement related, just kind of like how value-based purchasing works, readmissions, that side of the world. Not going to get into too much of this. So if you want to read it, go ahead. Nothing too crazy. And readmissions, there's the Medicare Advantage data for 6 measures, but MA payments are not included in the excess readmission calculation. So that was the biggest thing that we saw. Not going to get into too much of this. If you're in this interoperability world, you can kind of look at some of these technical changes. Again, CMS does look for comments to reduce burdens on providers. Quality reporting. Then they include a COVID diagnosis for 7 measures. Interesting, but no major changes. And here's what I talked about earlier, just in terms of in the thought, and as we talk about all these reporting programs, like I said, in the proposed rule, and I always said, love the terminology unleashing prosperity through the deregulation of the Medicare program. That was like the front page of when the proposed rule came out. Final rule doesn't really say anything about it. Well, we're taking your comments into consideration. But they did want to identify 10 regulations to be repealed. They want to reduce reporting burdens. We just went through a lot of things here, right, that are voluminous amounts of reporting. So we'll see if CMS wants to make any changes to that in future rulemaking. As a surprise, when the final rule came out, again, if you're in this world, in the interoperability world, they did issue a final rule related to that program. So you would want to take a look at it. Again, that's very niche stuff, not really related to the cost reported reimbursement, but it does impact ultimately CMS's markup rate that they give you for the base rate for meeting interoperability measurements. Okay, OPPS. So there's a few things in the OPPS proposed rule that are big in 2026, and like Ryan mentioned earlier, in early November, we'll see what the final rule says. What was interesting, though, right off the bat, was CMS said, well, we told you we would give you like 16 years to recoup this $8 billion from this 340B remedy payment, but we want our money faster. And I even think it was codified that they were supposed to take 0.5% off in 26 through, I don't know, like 2045, or it was way out in the future, maybe even past that. But now CMS is saying over like a 6 or 7 year period, they want to basically recoup 2%, so they get their money faster. And I'm thinking, and we just went through this presentation. I'm like, cuts, reduction in funding, OBBA, less people with insurance. Oh yeah, let's reduce OPPS payments too. It just seems like a reach, but it is something they proposed. I've heard, perhaps if CMS were to go through with either of these cuts, but certainly the 2% accelerated, that there could be a lawsuit attached to that, because what it does is it wipes out pretty much any update on the outpatient side to hospitals. So what we did out of curiosity was basically, if you could just look at the orange section here, and what we did was, there's a couple things that happen when OPPS comes out. First, the OPPS proposed rule still uses the wage indices from the inpatient proposed rule. But now that those wage indices are final, we could take them and bring them into the OPPS file. So we did that. We also know that the market basket is 2.6%, not whatever it was in the proposal, I think 2.4. So we updated for that. So that's what these columns represent. There are other budget neutrality factors that do change. There is a wage index budget neutrality factor in OPPS, so that will change, but we did not estimate that change for these amounts. But what you'll see is, after all these adjustments, that if CMS did not apply the 2% cut, right, we'd be at pretty much what the market basket is. We'd be at 2.6%. We'd be in a healthy position. But because of these cuts, and CMS's additional 2%, or you can call it 1.95, we're looking at, if you're lucky, getting a 1% increase over the prior year. And again, that comes back to your state or hospital specific impact. which accounts for things like wage index, et cetera. But you can kind of take a peek here at ultimately what every state would look at. You see a lot of negatives, right? So some states would see no increase at all or a decrease in payments because of CMS's reduction to accelerate the 340B recoupment. So again, you wonder why. Why, CMS? Why do you want to do this to us while we're going through so many other payment changes? And just for more of a weedy slide in the weeds, and this is interesting too, because we spend a lot of time on the inpatient side looking at the base rate. The outpatient has a base rate too. It's called the conversion factor. And basically, if you're curious how it works and what the trend is, if we look at 24 to 25, there was a 2% increase. And then right now, like I said, it's only a 0.9% increase due to the 340B adjustment. That increase would be closer to 2.4% if CMS maintained the adjustment at 0.5%. Like I said, when you look at outpatient, it's very similar to inpatient. What they do is they 60% of this number is applied to the wage index, the other 40 is not, and it's effectively multiplied against the APC weight to determine the OPPS payment. So in addition to the cuts, or at least the slow updates on the outpatient side, there are other things that CMS is doing that transition care that also impact the way hospitals are paid. This is relatively new. I'm sorry, I didn't get to that piece yet. I'm sorry. As I said earlier, they are proposing to make a move to site neutrality. Again, this could be step one of a few. And this does not matter if you're grandfathered in or not. What they are saying is that you would get the physician fee schedule for drug administration services, and that's like a 60% reduction as compared to what the OPPS payment would be. So, we know it's part of CMS's intention to move more into that site neutrality realm. That's where there's a lot of, in their eyes, low-hanging savings. But we certainly know in the hospital's perspective, the care is much more complex and costly, and there's certainly a reason that hospitals get paid in OPPS payments. So we're hopeful that the government listens and doesn't adjust too much out of that pocket. Inpatient only list, I think, and I don't remember, I thought that they proposed to exclude this a few years ago, but they're doing it again. They're proposing to start with musculoskeletal procedures. I suppose there's an argument where there are certain things that are more appropriate or can be done in an outpatient setting, but certainly I wouldn't want to have brain surgery in one or open heart surgery. So I hope they're not on the outpatient list or removed from the inpatient only. There should be certain things on the inpatient only list, So, but that is a transition, and it also is a transition in strategy, absolutely, as health systems are looking at the services they provide. If there are more things that are being reimbursed that are moving off the inpatient only list to the outpatient realm, well, we could see more providers looking at providing more in that outpatient setting, perhaps in ambulatory surgery centers. There are a few things here. Oh, I see a question. Oh, that's a good question, Mel. I believe so. So we'd have to look into that, Mel, and we'll do that. I've kind of asked so Mel's question is, would the impact of the 40% OPPS for drug admin APCs be reflective in the OPPS proposed rule impact file? I have to look. So that's a great question, Mel, and we'll look and get back to you on that. Thank you. Daniel, I see you making copious notes. I appreciate it. Thank you, homie. Okay, so another thing that's interesting, and this ties to all we talked about, the 340B remedy. CMS, the whole reason CMS had to pay $8 billion in remedies because they didn't previously conduct a proper survey on what the average sales price is on 340B drugs. And so what CMS was proposing to do, and it sounds like they really intend to do it, is 2026, there'll be some survey coming out that will impact what the average sales price is in the 2027 policymaking. Currently, it's 22.5% above average sales price. I don't know if a new survey is going to maintain that level. Curious what that survey looks like. Remember, it has to be statistically valid. So we need to keep our eyes peeled. And maybe if you don't submit the survey, there might be a penalty, but your payments might be higher. They have to have a certain N value, P value. It's been a minute.
Fred,
Anyway.
Joe Beck has a question. Joe, if you could post it in the panel, or I can find you and unmute you. He raised his hand.
Go ahead, Daniel.
Go ahead, Joe. I gave you the power of the mic. Unless you no longer have a question.
Well, he can type it, and it's been a minute since I heard Mr. Joe's voice, so it's nice to. Thanks for being on the call, Joe.
He said he doesn't have a question anymore. Thanks, Joe.
Okay. Thanks for participating, man. It's great to hear from you. Okay, so the other thing that's going on is there was a question on Medicare cost reports earlier. It's like a circular reference. So with CMS proposing the outpatient rules, they want to collect Medicare Advantage median payer specific charges. So that'll influence or perhaps dictate the weight of DRGs and how IPPS rates are set. Well, doesn't Medicare Advantage base their rates off of the fee for service? Are we delving into a black hole with a request like this? It seems it to me, but it is one of the CMS could be just curious, what Medicare Advantage is paying. So they are proposing a series of new cost report schedules. We'll see if that comes to fruition. They're also proposing in terms of transparency, if you use, it says, for payer-specific negotiated charges that are based on percentage or algorithm. Isn't that everybody? What's the definition of algorithm? That you disclose the 10th median and 90th percentile, so small, medium, large, of those charges under this rider health price transparency rule. So heads up on that if you're involved in charge master work and price transparency. There's some things that doing that'll reduce the quality rating scores. Don't have to get into this slide though. It's not too much in the realm of reimbursement. With that said, we are done. What I'll do, and unless there's other questions, I'm just going to preview what you all have or what we're going to send out after this. So these are, again, the intent of this is for us to give you guys an update, but also to provide a resource document, hopefully, making your life easier. I know what it's like to someone asks you a question and you're like, oh, I got to open up the final rule and find it. So we try to provide as much, solid information here to kind of summarize the world of reimbursement. So this kind of goes into why CMS changes that labor rate for hospitals with wage indices above 1, if you're curious about that. These are the rates for 2026. Again, you're already probably seeing them in the pricer, but it also shows, if you get that reduced rate, it'll show you what that is, and that's for not being a meaningful health user or not submitting quality data. And we know that impacts some hospitals. Oh, Andy's a good dude. He's got something. And these are what some other major rates are. It's interesting that the outlier threshold went significantly down this year. So it's very possible for providers to see an uptick in outlier payments. You might want to monitor that as something that is also changing.
Fred, there's a question. Has there been a correction notice to the 26
Oh, I hope
IPPS
not.
rule?
I hope not. And I don't know who would be doing that work. They always get me though. In fact, if there was one, I bet you it would be this morning where I didn't have time to update my slides. That's usually when they come out.
Well, who would be doing it, right, Fred? And I'm going to effort to look right now because you got me curious as well. It's a very good question. I think has there been a year where a correction notice has not been issued? So,
Correct.
I'll take a quick peek, but I'm going to guess nothing yet, only because. I mean, like you said, who's doing it? We're shut down at this point.
Well, yeah, we are shut down. I did hear though that CMS personnel that are involved with writing regulations are not a part of the furlough. I did hear that, believe it or not.
And Andy posted a comment to answer Mel's question. The Drug Administration is included in the OPPS proposed rule impact file.
Thank you, Andy. You see what happens when you have good group of people on the call. You have all the answers.
And for the record, I'm not seeing anything on the CMS website. So no correction notice to date. Doesn't mean it's not coming.
It's coming. And for a minute, they changed the name to, they call it a correcting addendum.
That's
But
right.
then I think they went back to correction notice.
Yeah.
So, okay. So just so y'all could see too, based on this, I find this interesting, again, the takeaway is it really depends on what state you're in. But this does show, at least according to our calculator, what the Medicare inpatient rate changes have been from 23 to 26. And we did break out urban, rural, and like I said before, urban hospitals. So those hospitals that are urban, but redesignated as rural. And just to give you an idea, but what I'd say is, I'll even go to our friends in California. It was a huge, huge pickup in 2024 when CMS changed the rural floor in California. But then you see, well, it's like, what have you done for me lately, right? And then although because it's hard to stay up so high once you're there, if you follow, right? You could have that one year where things are great, but then everything starts to normalize, especially when you have these dramatic wage index changes. And we see that. You could even see this year in New York would kind of be the opposite of that, where uh, in some of the earlier years, maybe that's a bad example. I'll use our friends in Texas. Some of the earlier years were lighter, and then the increase kind of goes up and up as strategies change. So feel free to peruse this. What I would say in looking at this is it's a state by state impact, and it's largely driven by wage index activity as well as uncompensated care activity. And with that in mind, before I get to the UC dish, these are all the states, like Ryan had mentioned earlier, where that basically receive a rural floor. So in every state, there is a portion of hospitals that receive the rural. There's no state where the answer is zero or even that close to zero. But there are states where 100%, and this goes to the fact, like we said, 72% of all hospitals across the country are receiving the rural floor. There are these states, 100% of those hospitals receive it. And even as you get into some other states, when you get into this 99, 98, those could be Indian health service providers or one hospital as a reclass somewhere else. But in general, every hospital receives the rural floor. And you start to go down to more and more states, and you can see, even though, it's not 100%, there are still a decent number of providers that receive their state's rural floor. The lowest we have it is over here in Arkansas at 27%. So just to put that in some perspective for everybody, if you're curious. There are some states that do not have a rural area, and they're all urban states. And these are the percentage of hospitals that get the what is called the imputed rural floor. And then we have states that are frontier states where the wage index is 1. And so as it stands today, 100% of hospitals in those frontier states receive that wage index. This is that you.
It makes
go
it
ahead.
easy for budgeting,
Absolutely. This is the UC dish trend. If you're curious, again, we did this by state. What I found interesting about this, and I invented some acronyms. So I invented this UCIP. I was curious, like, what percentage of your uncompensated care payments are is it to your IPPS payments? So, because there is a difference between expansion and non-expansion states, which you can clearly see. So Texas has the largest degree of uncompensated care in the country. And if you look here, at least according to our calculations, 18% of all IPPS payments in Texas are related to UC dish, where, you get to a place like expansion state like New York, still, I mean, 2.3 billion is a lot of uncompensated care, but as a percent of their payments, it's 5% compared to 18. Just to kind of put things in perspective in terms of what this money means to hospitals. It's certainly significant, but it's going to change. We're going to see a lot of changes, like we talked about earlier, with Medicaid enrollment and increases in uncompensated care. That is it, everybody. I tried to make it exactly an hour and a half. And we did an hour and 22, but I don't think 8 minutes back is bad for everybody. Appreciate everybody signing on. We're going to do a follow-up. So I think this is being recorded, and then a follow-up so you have access to the presentation. Absolutely, anytime you have a question, please feel to reach out to any of us. And we appreciate working with you all. Like we always say, we do a lot of homework here, but we learn a lot from you guys, and it's great teamwork. So appreciate it.